Morning, everyone. I have the privilege of introducing Dr. Ann Susskind this morning as our grand round speaker. I'm here on behalf of Dr. Marshall Stoller and Ben Breyer. I know some people are out on spring break this week. So Dr. Susskind and I first met, I believe, at the SUFU meeting. Well, I don't know if we met then, but I had the privilege of getting to see her speak on her frailty research at the SUFU meeting in 2017, which was the first SUFU meeting I attended. And I remember just being so impressed by your research and your work at that time that subsequently at the SWU meeting in 2018 was when I think we officially met and went out to dinner. And at that time, I had just casually mentioned, maybe we could be colleagues one day. And fortunately, I manifested that, and now here I am. So a little bit about Dr. Susskind's background. So she is a professor of urology here at UCSF, where she holds dual leadership roles as vice chair of faculty affairs and chief of neurourology and female pelvic medicine and reconstructive surgery, now known as URPS. We've changed the name a couple times. She graduated from Hartford College and she attended medical school at Albany Medical College. She completed her urology residency at the University of Connecticut and then completed a fellowship at the University of Michigan. And so far, she's had an illustrative research career where she has received extensive NIH funding, R01s, R56, R03s, K12s, T32 grants. Very, very impressive. She's also an outstanding leader in our department and a great mentor to many of us, including myself. So I'm very excited to welcome Dr. Susskind as our grand round speaker today.
All right, good morning, everyone who's here and on Zoom and watching us recorded later, maybe. And thank you, Michelle, for the introduction. I remember that dinner very well, actually. I remember the SWU, I think it was in Hendrickson, and then we went with a small group into Las Vegas and had a nice dinner with tapas. I remember that exactly. And I remember you saying the job piece. So here we are. All right. So as I was kind of preparing for this talk, I was thinking about the first and last time I gave grand rounds, which was in 2015. And I remember it was at the end of my first year on faculty. And, I was in a very different place then than I am now, but actually a couple of my slides are the same, which is kind of funny. So it was fun for me to see how things have evolved over the time here. So here are my disclosures and current funding. So today I'm going to talk to you about frailty, which is a topic that, as many of you know, is very near and dear to my heart and that I'm very passionate about. And as you all know, I'm sure, the population is aging and it's aging very quickly. So here is a graph of projected population trends. And you can see here that well, first of all, over 10,000 Americans turn 65 every day in this country, okay? And most of them are expected to live beyond age 85. So not only is the population aging, but the aging population is living longer and longer. And between, I think it's 2010 and 2040 or 2050, the older population is expected to double in this country, okay? So why is this important? Well, almost half of all urology visits, and this is older information, it's probably even higher now, are for patients ages 65 and older. And this always impressed me that we are actually third of all specialties behind ophthalmology and cardiology. And surgery in older adults is common, right? We all know this. Over 35% of all surgical procedures are performed in older adults, and in urology, it's as high as 62%, okay? And the assumption is that surgery is getting safer over time, and this is largely true. And it's due to things like advances in anesthesia, minimally invasive techniques, which we do a lot of in urology, and patients have high expectations. The days of people dying on the table are largely gone. People expect to survive their surgery and to do well afterwards. And there are many studies in the literature, case series that tout very good outcomes in older adults. This is just a random sampling, really, but there are many more. Here's one for percutaneous nephrolithotomy in those 80 years and older, one in radical cystectomy, and one in prostate cancer. And these are data from the National Surgical Quality Improvement Program, which is put out by the American College of Surgeons. You may have heard of NSQIP. And here we're looking at complications in blue and mortality in orange with increasing age among older adults undergoing common general surgery procedures. So not surprisingly, both increase with increasing age. So the question really is, how do we decide which older adults we should operate on and which ones maybe we should consider alternative strategies? So today, that's going to be the focus of my talk, and I'm going to talk to you about this conceptual framework. So this is how I think about it. So in the middle of these circles, or this Venn diagram, we have the optimal treatment decision. So the idea is that the optimal treatment decision is really a confluence of understanding the risks and benefits in this particular population, the patient's own goals of care, and frailty. So we're going to talk about what is frailty. Frailty as it relates specifically to urologic surgery. How do our patients in particular fare? Patient goals of care. What outcomes matter most to older patients? Some of this may surprise you. And frailty and surgery to improve quality of life, which is what I spend, as you all know, the majority of my clinical practice on, and some practical tips and tricks that you can take home to your practice and start using today if you wish. So starting off, what is frailty? It's the type of thing that we think we know it when we see it. And in some ways that's true. We're very good at kind of identifying patients who are very frail and those who are not very frail, but we're actually, the literature has shown, we're not very good at picking out everybody in between. We think we are, but we have a lot of misses. So here's one definition of frailty, of which there are many, but I think it's a helpful way to start. So frailty is a condition or syndrome which results in a multi-system reduction in reserve capacity to the extent that a number of physiological systems are close to or past the threshold of symptomatic clinical failure. And as a consequence, the frail person is at increased risk of disability or death from minor external stressors. Now, I underlined a couple of words here. Minor external stressors, of course, surgery is often more than a minor stressor, right? And I also underline the word threshold because I think this just resonates, rings very true, right? We see patients kind of reach a certain point when things sort of start to unwind, and it's almost like a domino effect. So I'm going to introduce this diagram or this illustration, and I'm going to come back to it several times throughout the talk. So this is mapping out physiologic capacity on the y-axis and time on the x-axis. And we're looking at the effects of major events in frail older adults. So you can see at node 1, there are two different trajectories, right? So the one on top is a trajectory of sort of a normal physiologic trajectory. And the one on the bottom is an accelerated loss of capacity. So that's node 1. At node 2, we have an acute event. So in our case, that would be surgery, right? And then you see an immediate decrease in reserve capacity, and then a recovery to node 3. And then there's this another branch point. So you can either kind of recover to the prior trajectory that you're on, or you can have a further decline in your functional capacity, which is what we typically would see in individuals who are frail. Now, this is the cycle of frailty that was popularized by Linda Fried. And I like to show this because it shows frailty as sort of a very dynamic process. So you can start anywhere on here, for example, sarcopenia, which is loss of muscle mass, and that can lead to things like decreasing resting metabolic rate, decreased strength and power, that leads to decreased walking speed. And you can see it just kind of goes on in the cycle. And then you can even have other diseases and other processes enter in and accelerate that cycle. This is something that's very important because I think there's a lot of confusion between these three terms. So frailty, disability, and comorbidity. People tend to use them interchangeably, and they are actually three distinct concepts. So that's really important. So certainly there's overlap between things like comorbidity and frailty, but you don't have to be comorbid or disabled to be frail, right? You can be frail from other aging related processes. So that's an important point. So Linda Fried developed the Fried frailty phenotype. Perhaps some of you have heard of this. It's very kind of widely circulated. And she did this using data from the cardiovascular health study. She looked at over 5,000 men and women who were living in the community, 65 years and older, and she measured them or evaluated them at baseline and up to 7 years after, or 7 years later. And she came up with these 5 domains and defined frailty as the presence of 3 or more of these domains. So things like weight loss. So this is unintentional weight loss of 10 pounds in the last 6 months, weakness, which is measured by grip strength, poor endurance and energy, which is measured by self-report, slowness measured by a quick walking speed test, and low physical activity also measured by self-report. And she mapped these over 7 years, and you can see the bottom line is the frail individuals, the middle line are those who are intermediately frail, and the top line are those who are not frail. And you can see this tracked very, very well with mortality over time. Now, that's sort of a cumbersome and time-intensive way to measure frailty, but so there are many different ways to measure frailty, and I think almost everybody in this room is probably familiar with the Timed Up and Go test if you've been to our Parnassus and Bayfront clinics. And basically, the Time Up and Go test is this. The individual is seated in a chair. They're instructed to stand up, walk to a mark on the ground that's 10 feet away, turn around and sit back down. And what I like about this is it's very parsimonious. So it incorporates core strength, so getting up and down from a chair, cognition, following instructions, balance, speed, and it's very quick to administer and scalable for a busy clinical practice. And this was first popularized in the surgical literature by Tom Robinson, who is a colorectal surgeon out of the Denver VA. And he looked at cardiac and colorectal surgery patients and measured the Timed Up and Go test and tracked postoperative outcomes, or excuse me, postoperative complications. And not surprisingly, those in red who had the slowest Timed Up and Go test times had markedly higher 30-day complications. And he also followed them 5 years and looked at mortality and found that the Timed Up and Go test was highly predictive of 5-year mortality. So moving on to frailty in urologic patients, and this is a picture, you probably all recognize this from just about 20 minutes north of us at Muir Woods, one of my favorite places. So we, as many of you know, started measuring the Timed Up and Go test in December of 2015 in all of our patients in our adult urology subspecialty practice who are 65 and older coming to each of their visits. And this is done by the medical assistant at the time of vitals and recorded into the medical record. And we've actually published on this, and it takes less than a minute for the medical assistant to explain the test, administer the test, and record it into Epic. So this is something that is highly scalable and I think very useful. And the reason for that is oftentimes we see a patient, we open the door, we walk into the room, the patient is seated on a chair or the table, and we don't see them moving through the world, and we really miss a lot of information. So now I look at the Timed Up and Go test number before I get into the room, and I already know where they fall in the frailty spectrum, and that's really helpful information for me to have when talking to the patient. So here is data that we published on the first 1,000 or so patients that were in our database. And this is work done by Jace Pendilian. She was an MSTAR student who spent a summer with me several years ago. MSTAR is an NIH-sponsored program for medical students who are interested in geriatrics. And you can see here, not surprisingly, with increasing age, we have increasing rates of frailty as shown in the red bars here, but something, and I also want to kind of pull your attention to overall 45% of patients in our clinics, and at this point, this was our Parnassus clinic, were pre-frail or frail, okay? So kind of wrap your head around that. We're seeing a lot of patients who are frail and pre-frail. And the other thing I want to point out here that I think is important to understand is I don't want you to think that all older adults are frail. Actually, the older age groups have more heterogeneity in their timed up and go test times. And I circled there the standard deviation, which is our level or measure of variance. And you can see the variance is much bigger in the older age group. So I really don't want you to take away from this talk that the older you are, that necessarily the more frail you are. It actually becomes more of a heterogeneous population. And then we looked at the same patients by urologic diagnosis to see, are there some diagnoses that are associated with more frail phenotypes, and there are. So patients who came to see us for recurrent UTIs, neurogenic bladder, overactive bladder, tended to be more frail compared to those who came to see us for male general urologic problems, stones, and male urethral conditions. However, in general, all the patients that are seeing us are more frail compared to the kind of age-matched numbers that I published below of the general population. And so we went on to do more work with this. And interestingly, we're the first to show that frailty and not age was associated with the following diagnoses. So recurrent UTIs, overactive bladder, detrusor overactivity on urodynamics, male lower urinary tract symptoms. So as I've alluded to before, there are many different ways to measure frailty, and here's another one. And this is for the NISQIP database that I mentioned before. And this is considered to be what's called a deficits accumulation model. So there are 11 different deficits here, and you sum them up and divide by the total of 11, and you get a score. And the higher the score, the more likely they are to be frail. So we use data from, again, the NISQIP database, and here we looked at the 20 most commonly performed urologic procedures that were in the database. And here I'm showing the impact or log odds of increasing frailty on complications associated with common urologic procedures. And what's interesting here, anything to the right of that red line is statistically significant, so almost everything was significant. But everything at least showed the trend, and the trend was the same. Increasing frailty was associated with increasing risk of complications. But what's interesting here is look at the list of procedures. It spans the gamut from complex procedures like cystectomy to less complex procedures like hydroceles. But regardless of the complexity of the procedure, the trend was the same. So it's not okay to think, oh, it's just a minor procedure, we don't need to consider frailty. That's not what we're seeing here. And just to delve into this a little deeper, I made this point before, but looking at any individual age group, you can see, different levels of frailty in that group. And these data actually included patients who are 40 to 50. So you don't have to be necessarily older to be frail. And then we did a similar study, but here the outcome was discharge to a skilled or assisted nursing facility, and the trends were the same. So your patient survived their surgery and made it through the immediate postoperative period. What happens to them next? So we wanted to understand where older adults undergoing the high-risk cancer surgery spent their time the year following surgery. And so how much time in a hospital, in a facility versus at home. And we looked at Medicare data and data from the minimum data set, which is quarterly survey data of all nursing home residents, and high-risk cancer surgery shown here. And we just very simply calculated the adjusted percentage of time spent in each of these places. So the majority of these patients underwent cystectomy. Mean age was 74. The majority were male, and hospital length of stay was 12 days. About a fifth were discharged from the surgical episode to a facility, and almost a third died within 1 year of their surgery. Now, here are the results. So in terms of hospital readmissions, on average, patients had 1.5 in the year after surgery, totaling about 20 days. And in terms of facility admissions, also 1.5, totaling 37 days. So collectively, they spent almost 2 months away from home. This is after their discharge from the surgical hospitalization in the year following surgery. So I think that's helpful information for people to understand. Now, what other outcomes are important for patients? And does anyone recognize this place? It's Point Reyes. Well, gosh, I don't know specifically what beach, but you could be correct. So many of you know I used to volunteer as a wildlife docent at Point Reyes. It's one of my favorite spots, and this is a picture of Sculptured Beach. Is that right? Okay. So this is an interesting study that looked at treatment preferences in patients with limited life expectancy. So they took 226 patients, 60 and older, with limited life expectancy from cancer, CHF, COPD, and they gave them hypothetical scenarios to assess treatment preferences according to the burden of the treatment. So they defined low burden treatments as treatments that lasted a few days to a week of hospitalization with minor tests like imaging and blood tests and therapies like IV antibiotics and oxygen supplementation. Now, high burden treatment lasted at least a month in the hospital, included many minor tests, plus more complex and major interventions like ICU care, surgery, and mechanical ventilation. And then they gave them possible outcomes, and the outcome of not receiving treatment was death from the underlying disease. This will make more sense on the next slide. So here's what they found. So starting at the top, if someone was offered a low burden treatment, but they would return to their current state of health, 98% said they would take that, right? Makes sense. Now, if they're offered a high burden treatment, but the return was to current health, 88% would want to take that. Now, this is where it gets interesting. Patients who are offered a low burden treatment, but the result would be severe functional impairment, only a quarter would sign up for that. And if they're offered a low burden treatment, but the result is severe cognitive impairment, 11%, okay? Remember, the alternative was death from the underlying disease. So this is kind of telling us that things like functional impairment and cognitive impairment may be more important or more perceived to be more detrimental than death to many patients. This is an interesting study done by our geriatrics colleagues at UCSF, and they wanted to understand what activities matter to patients after surgery. So they looked at almost 200 adults having elective surgery, and they just simply asked them, what are the activities most important to you to be able to do when you return home from surgery? And they asked them to list up to 3, and then they followed up with them 6 months later to see if they were able to do it. Not frail patients, just patients in general. So this is the distribution of what patients valued. So number 1 was recreation, things like reading, cycling, bowling, garage sales, knitting, followed by mobility, things like walking, stair climbing, driving a car, followed by activities of daily living, then instrumental activities of daily living, which are kind of more high functioning ADLs, and followed by social activities, enjoying time with friends, family, going to church, and playing bridge. So 6 months later, when they followed up with these individuals, almost a third were unable to perform at least one of their valued life activities. And this was actually highest, or the fewest number of percentage of patients were able to participate in the recreational activities that they valued. So this just kind of gives you a general idea. Again, there are things more than looking at 1-year mortality and 30-day complications that are obviously very important. And so it's really important for us as surgeons to understand that, and we really need to help facilitate the patient's own articulation of their goals and what's important to them, and make sure it's our job to help align the treatments that we're offering with their goals. So it's important to ask open-ended questions, and some important considerations, like I've alluded to, are things like life prolongation, function and independence, maintenance of cognition, and comfort and quality of life. And in the interest of time, I'm not going to go through this in detail, but here's some examples of different domains and questions that we can ask to elicit a patient's prominent healthcare goals, understanding their unspoken concerns, source of life's meaning, etc. So how long will it take for an older individual to return to normal, quote unquote, function after surgery? So this is a study looking at the natural history of this recovery among almost 400 patients, 60 and older, undergoing major abdominal surgery. And again, not frail individuals, but all comers. And they did functional assessments preoperatively and up to 6 months postoperatively. So I'm bringing you back to that, one of those first images that I showed you at this talk, at the beginning of this talk. And here we're looking at time 0 is the time of surgery. So these are activities of daily living. They take a big decrease in ability to perform these, but by 6 months, it looks like they're nearly back to where they started. And then here are the individual activities of daily living. So you can see things like bathing, dressing, transferring from bed to a chair, don't quite recover at 6 months, and they take the longest. And then these are the instrumental activities of daily living. So these have a more profound impact as a result of surgery. And then 6 months later, they're not fully back to their baseline necessarily, particularly things like doing housework, household shopping, laundry, and driving. Okay. So, but we're talking about frailty today, right? So what about patients who are frail at baseline? Well, we'd imagine it would be a little bit more impacted by surgery. And this is a study done by Emily Finlayson, who probably many of you know or have worked with, one of our beloved colorectal surgeons and one of my mentors. And she looked at functional trajectories in 1-year mortality in nursing home residents who underwent major surgery. And that blue line is that same kind of trajectory that we were looking at before. And time 0 is the time of surgery. So again, you see that dip in the ability in this case to perform functional activities and as measured by ADLs. And then measured up to 1 year after surgery, you can see they're not recovering to the baseline trajectory that they had prior to surgery. And post-operative mortality 1 year later was about 55%, so quite high. And in general, nursing home resident 1 year mortality is 20 to 30%, so much higher. So one of the first kind of studies that I did when I was here with a GEMSTAR grant was, well, what about surgeries that we consider to be relatively minor, right, that we do all the time? So similar sort of study design, but I looked at the surgeries performed here, and you can see here that the magnitude of effect is a little bit different, but we still see a decrease in functional trajectory that doesn't recover 12 months later, and 1 year mortality is about 44%. So lining them up, you can see major surgery, minor surgery. Again, all surgeries in frail older adults have an impact. And then I throw this in here because I think it's very interesting. So here we're looking at the same functional trajectories stratified by baseline function. So the line on the top are individuals with the highest baseline function. And you can see here that they actually have the biggest deficit or delta or change in function. So I put this here because I think we often think that those with the best functional status are the best surgical candidates, right? But they also may be the ones with the most to lose. So, I think it's just a different way of thinking about it. Okay, so what about procedures done to improve quality of life? You can see there are a couple of elephant seals here. They look like logs, but they're enjoying their quality of life for the time being. So starting with surgical outcomes. So this was our first R01. We looked at surgery for bladder and bowel dysfunction. We looked at Medicare inpatient, outpatient care claims, and again, the minimum data set for nursing home residents and all these different types of surgeries. And then we start off at least by propensity score matching nursing home residents to community dwelling older adults based on the type of procedure, their age, sex, race, comorbidity, and year. We had over 55,000 beneficiaries. And not surprisingly, here are our results. So nursing home residents had increased rates or relative risks of 30-day complications and 1 year mortality. Not incredibly surprising, but here it is. And then we also looked at 1 year mortality, and not surprising, our nursing home residents had worse 1 year mortality compared to matched community dwelling beneficiaries. We did another project looking at nursing home residents and inpatient prolapse surgery, same kind of setup, propensity score matching based on all the characteristics shown here, and same types of results. So what exactly accounts for these differences? All we could really measure here is whether someone was in a nursing home or whether they were not in a nursing home. We suspect that frailty has a big part to do with this, but we can't measure it independently. So then, magically, there was a frailty index that was developed specifically for use in Medicare claims that became available. And this is a deficit accumulation model of 93 variables in various files of the Medicare data. And it allows you to calculate, it's a weighted kind of average, it's complex coding, but it allows you to calculate frailty and measure it as not frail, pre-frail, mildly frail, and severely frail. So we were very excited to get our hands on this. And this was work that Michelle did with us when we were just starting to use the frailty index. And we looked at sling surgery in older adults in almost 55 or 54,000 Medicare beneficiaries. And we used the claims-based frailty index. We controlled for patients having concomitant surgeries for prolapse and hysterectomy, and we looked at 30-day complications, specifically UTIs, because these are the most common complications, and the rates of repeat procedures for stress incontinence or for sling removal. So not surprisingly, we saw increased rates of 30-day complications, 30-day UTIs, and also need for repeat procedures with increasing frailty. So we did this in many different populations, and this is work that I did with another MSTAR student that spent a summer with me. And here we're looking at pelvic organ prolapse surgery and hospital length of stay, 30-day complications, and 30-day UTIs, and the story is the same. Then we've also, Farnoosh recently did a project looking at procedures for male stress urinary incontinence, so male slings and AUSs, and same sort of trend here. So increased rates of 30-day complications with increasing frailty, and also increasing rates of revision and removal procedures with increasing frailty. Now, interestingly, for the second piece, the increased rates of revision and removal procedures were associated with frailty, but were not associated with comorbidity. So clearly, again, like I talked about before, they are distinct concepts, and it's important for us to measure both. So what about functional outcomes, right? We spent a lot of time talking about how important those are. So back to the nursing home residents. Here's data that we worked with for suprapubic tubes. And again, we're looking at physical function, and we see a big dip in physiologic trajectory measured by activities of daily living score here, and follow them 12 months later, and you can see there's a huge deficit, right? And it doesn't even come close to recovering to the preoperative baseline. And this is a suprapubic tube placement. Now, I'm sure there are other underlying diseases going on, but you can see here that clearly that trajectory starts to dip at the time of surgery. And so I think that this is important to keep in mind. Again, we consider suprapubic tube to be a relatively minor surgery. We also measured cognitive function in this cohort by the BIMS, B-I-M-S, and you see a little dip at the time of surgery at time 0. I think what we're seeing here is the BIMS isn't a very sensitive measure. It's really hard to measure cognitive function, but I throw this up here just to let you know that we're thinking about it. I just don't think that we have good tools to measure it in this population. And then we looked at frailty stratified by looked at mortality, 1-year mortality, and it stratifies with the frailty index, as we've seen in other studies. Now, this is an interesting study where we looked at TURP in nursing home residents. And because of the minimum data set, we were able to reliably tell if people had catheters. And so these are the functional trajectories, and they're stratified by whether or not someone had a catheter at baseline, so before their TURP. So those with the catheter in the red dotted line before. So interestingly, they have poor functional status to start with. But this is what I really want to direct your attention to. So this is, look at the bar graph on the right. So this is Foley status 1 year after TURP. So on the right, our patients had a Foley before their TURP, and 1 year later, 94% of them had a Foley, okay? So basically, we do a TURP, right, to help people urinate, and it was apparently a not successful procedure in 94% of these patients. So this is something that's really changed my practice in frail older adults with catheters. I consider that very carefully whether or not to do a TURP in this population. Rarely do we see a signal this strong in these type of data. So I know I'm sounding a little bit like a broken record, right? Increased frailty, increased complications, increased rates of repeat procedures, increased mortality. Is that always true for all types of procedures? And the answer is maybe not. So our current R01 is looking at minimally invasive surgery for overactive bladder. And we started off by, again, looking at nursing home residents. And we looked at over 1,600 onabotulinum toxin A injections, and we measured success as repeat injections within 1 year, and secondary outcome of use of a catheter within 3 months, because we know that Botox can cause urinary retention. And we wanted to see if it was more common in these nursing home residents. And we also looked at over 1,000 beneficiaries who underwent sacral neuromodulation. And for them, we defined success as device or IPG, so implant, which IPG stands for implantable pulse generator, within 90 days. So they went on to their implant or their stage 2 procedure in some cases. And then the secondary outcome was their device explanted within a year. So starting with onabotulinum toxin injections. So 34% had repeat injections within 1 year, okay? And age and female sex were associated with repeat injections. But interestingly, frailty was not associated with whether or not someone had a repeat injection. So we thought that was interesting. And then at 3 months, 14.6% had some sort of catheter. And this is actually on par with what we see in our general population. I quote patients 10 to 20%. And so I was actually surprised that it wasn't higher. And interestingly, having a catheter was also not associated with frailty or with any of these other factors that we measured. Now moving on to sacral neuromodulation. So overall implant rate was 58.4%, which if you look at large population-based samples is pretty, on par. It was lower among those who are having the PNE, so that's the temporary lead that we sometimes place, and it was higher among those who are having the formalized staged implant, which isn't too surprising because they're already kind of on the pathway to getting an implant. And interestingly, this was also not associated with frailty, which surprised me. And device explant overall was 9.3%. That's on par with the general population. It was a little bit higher in those who had the staged procedures and a little bit lower in those who had the PNE, which I think also makes sense. And again, not associated with frailty. So, of all the different procedures that we've looked at, and we've looked at many and even more than I've presented here, these were the first procedures that didn't show that signal. So if we we just don't know how to predict clinical success in these patients. So how are we choosing patients? So this might be a tiny bit off topic for a second, but it's really interesting and really new data. So I wanted to share it with all of you. So we wanted to look at non-clinical factors that might be driving treatment selection in this population. So again, we looked at our Medicare population, and here we're looking at levels of geography. So each kind of area that you're looking at is an HRR, or hospital referral region, which is one way that in health services research, we often kind of depict different levels of geography. And you can see here a heat map showing variability in selection, or sorry, maybe not selection, but in what type of procedure is being done. So this is showing this is showing patients undergoing sacral neuromodulation compared to onabotulinum toxin A, okay? And it's adjusted for a whole bunch of beneficiary characteristics, including things like comorbidity, frailty, age, et cetera. And you can see those with the darker kind of maroon color. The darkest one is 80 to 100% of matched beneficiaries undergo sacral neuromodulation as opposed to onabotulinum toxin A, and those with sort of the lighter or the pale yellow color are more higher rates of onabotulinum toxin. And so we measured variability by something called the median odds ratio. And in this case, it was 4.2. So basically that's saying that there's a 4-fold difference in what procedure you will get based on what geographic region you live in. So this is actually a pretty big signal. We also looked at individual provider. So does the surgeon that you see make a difference in the procedure that you get? So we did, what I'm showing you here is a caterpillar plot. And each one of those lines is a different surgeon or a different physician who does both types of surgery. And you can see here on the bottom left, all those providers are, the majority of the patients that they're seeing get Botox. On the top, the majority are getting neuromodulation. In between is every kind of different ratio between the two. So here what we saw when we measured the median odds ratio was a median odds ratio of 33, which is off the charts high. So there's a huge amount of variability of what procedure you get based on what physician you see. Okay. So kind of coming back to how do we decide what procedures we want to we do, and how do we discuss this with patients? It comes back to kind of efficacy and risk, right? So of course we want procedures that are high efficacy and low risk, and we want to avoid doing procedures that are low efficacy and high risk. But there's so many things to consider, right? Often when I give this talk, people want me to tell them, well, no, tell me when to operate and when not to operate. I get that question all the time. And you can't do it, right? Because everybody's so individualized. Every different situation is complete, has its own nuances. And then there's different disease conditions that we're treating. And so some important considerations are, is this procedure going to prolong life? What are the effects on quality of life? What about functional outcomes, cognitive outcomes? But we ideally want to be choosing our procedures based on these conversations rather than where you go to have your surgery or by what surgeon you go to, right? So one of the things that we did was we worked on creating a risk calculator to kind of help individualize the risk a bit. And so again, in Medicare claims, these are the 93 different components of the claims-based frailty index. So we took all of these. We took the 17 components of the Charlson Comorbidity Index, and we took all these different types of procedures that we had data for. So mid-urethral slings, all different combinations of prolapse repair, plus or minus hysterectomy, suprapubic tube, and all the different types of bladder outlet procedures that we could measure. And this is oversimplifying it. This took many months of work, but we put all that together. We did a lot of analyses, and we came up with 13 variables that were most highly predictive of our outcomes. And we added age and whether or not someone lived at home or in a facility. So here are the different, the most predictive variables in our model. And I won't get into the details, but we did a lot of statistical testing. We looked at C statistics, Breyer scores, the Spiegel-Halter values. So this is looking at model calibration, discrimination, and accuracy. We built tests for model fit shown here. So these plots, you want your dots to line up on the line, and the closer they line up on the line, the better the model fit is. So these are just some kind of exemplary plots. And we created the UroArc, and Farnoosh was instrumental in getting this together. So this is the Urologic Surgery for Older Adults Risk Calculator, and it's free, it's publicly available, it's online. There's still a couple of kind of cosmetic glitches that we're working on, but all the data is there. And so what you do is you go to this calculator, you choose the type of procedure, the individual characteristics of your patient, and it gives you an output that looks like this. So you can see here, I put in some characteristics to make the person look frail, right? So you see all these red lines, but not everybody's going to be red. And then it compares you to the average risk. So this is based on all beneficiaries undergoing these procedures during this time period. So, there are limitations and strengths to this. So the limitations are the Medicare claims, of course, lack qualitative outcomes that we know are important. So future work needs to be done in that area. But the strengths are, this is huge power. So the data that we have, and I didn't mention this before, but we have 100% of Medicare claims for fee-for-service beneficiaries undergoing all the procedures that we looked at. So these are real-world outcomes with great generalizability. This isn't data aren't data from a randomized controlled trial of surgeries done by the expert in the world, right? So these are real-world outcomes. So I promised I would leave you with some practical tips and tricks. that you can implement into your practice if you wish. One is measure frailty. And it doesn't really matter how we measure it, but I just encourage you to measure it. If you're at UCSF, likely you're using the timed up and go test, and I really encourage you to use that, to incorporate that into your flow, into looking at your vitals. Look at the timed up and go test score. I find it hugely helpful. Another way, I'm just going to introduce this, is another great way to measure frailty is the Edmonton Frail Scale. Now, this takes time to complete, so it's not for every patient, but if you have particular patients, or maybe you're doing a big surgery and you have concerns, you can fill this out with your patient. And actually, it's been shown that completing the Edmonton Frail Scale basically gives you as much information as a geriatrics consult, which is great because we do not have enough geriatricians. There's a huge shortage of geriatrics trained physicians in the workforce. So this is something that I think is a great tool to have. And what I love about it is it breaks it up into different domains. You can see things like cognition, general health status, functional independence, and there are questions for each of them. So if you determine a deficit in a particular domain, it's actionable. You can send someone to a geriatrician. You can send them to, physical therapy. You can do things based on what component of frailty they have here. So number two, this is a resource put out by, again, American College of Surgeons and the American Geriatric Society. They have a great online kind of guideline that can give more specifics if you're interested in learning about this more. And they go over things that we've talked about, like cognitive ability and capacity, how to measure these things, functional status falls, frailty, treatment goals, expectations. There's an A-Way white paper. I actually contributed to the sections on frailty and physical function. And you can see there's all these different areas here that can be helpful. So this is also available online. Of course, the American College of Surgeons NISQIP surgical risk calculators. So this is similar to what we developed, but this has different procedures. So the only downside of this risk calculator is it's a little bit limited in the procedures that they have, but they do have a lot of procedures, and it gives you outputs that looks like this. So this can be helpful in terms of determining the risk for your individual patient, also free and publicly available. And then finally, this is really cool. Have any of you heard of ePrognosis? Oh, yes. Okay, that's exciting. This is the only group I had talked to that may know of it. So this was created at UCSF by our geriatricians, and this is also online, publicly available. It's actually a very highly trafficked page, which is great. And you go there and they guide you to different risk calculator or life expectancy calculators based on what you're looking for. So these are just some examples of a couple of indices that I filled out. And one of them gives you kind of a number of year life expectancy and then a 5-year and 10-year projected mortality. Now, I've never done this and kind of showed this to a patient, but this is helpful I think, if you want to contextualize or kind of get a general idea. Sometimes we're thinking about weighing different options, and it's nice to know how likely is 5-year or 10-year mortality, et cetera. So that's a nice tool to have. So coming back to where we started, our conceptual framework, we talked about frailty. So we went over the definition, the free criteria, timed up and go test, and many other ways to measure frailty. We talked about patient goals of care. So what matters most, things like function, cognition, valued life activities, and really important, asking the patient. And then we talked a lot at the intersection of frailty and risks and benefits, right? And the more data we have on the more types of procedures, I think the more helpful this is. So we talked about specific outcomes related to urologic surgery. We talked about complications, discharge to a skilled or assisted living facility, where your amount of time spent at home versus in the hospital or facility. We talked about physical function a great deal. and outcomes for surgery performed to include quality of life and kind of the nuances of, is this a life prolonging procedure? Is this is this a procedure that's mainly here to, or we're mainly considering to improve quality of life? And our sort of comfort with risk will be different in all those different scenarios, right? You'll maybe accept more risk if this is to prolong life, and you don't want to accept as much risk if this is to make life more comfortable, right? So in summary, nationwide, frailty is common among older adults undergoing urologic surgery, and short-term complications are high, even in less complex procedures. Long-term outcomes beyond 30-day complications are important to consider, things like physical function, cognition, valued life activities. And I hope I've impressed upon you that there are no minor procedures in frail older adults. So by measuring frailty, ultimately, you can really make a difference in your patients' outcomes in lives. So one more thing, just a shameless plug, because I know I have a group of trainees here. If anyone's interested in getting involved in our work, these are kind of the current projects that we're working on. So funded by our R01, continuing to work on data, looking at the minimally invasive therapies for overactive bladder. This is using Medicare claims data. We have a fantastic team. We meet every Tuesday. We also do a lot of teaching. So like this week, we went over how to review an article. A couple of weeks ago, we went over how to write an abstract. We've gone over how to write the different sections of manuscripts, et cetera. So it's all kind of woven and it's a fun group. Also, I didn't talk about this today, but another kind of piece of work that we're working on is a collaboration I have with one of our qualitative researchers that we're doing qualitative work on persons living with dementia and urinary incontinence and their caregivers. So we're just recruiting now for that. We're doing individual interviews and interviews of dyads, and we're also doing some interesting work on photo documentation of barriers in the home. So those are some exciting things. If anyone's interested in getting involved, feel free to reach out. And really, it's a huge team of people who I've worked with, from medical students to residents to faculty to mentors. So it is really a team effort, and I want to thank and acknowledge everyone.